to welcome Kelsey Genovese. Kelsey is a physician assistant who, prior to starting with the University of Utah in May, practiced family medicine for 7 years in rural and underserved populations in California and Washington. She now works in the University of Utah's free PrEP clinic with infectious disease and performs public health detailing with AIDS Education Training Center, where she meets with providers individually to offer education and consultation on sexually transmitted infections and PrEP. Kelsey, the stage is yours.
All right. Can you hear me okay? Wonderful. Let me pull up the slides. And you can see these all right? Yes? Wonderful. Okay. So there's a bit of information to go through today. The last large chunk is cases. So don't panic if we're moving a little quick. We'll have time for questions and to go through things. I don't have any disclosures besides the fact that AIDS Education Training Center is funded through HRSA, so I do have to show this slide. Public health detailing, as Caitlin mentioned, is half of what I'm doing with the AIDS Education Training Center. It is an educational outreach where we meet with providers one-on-one to do individualized evidence-based medicine. This is the first year for Utah for having a program like this. They've existed in other states for 25 years. This first year we are focusing, as Caitlin said, on STIs and PrEP, anything related to that. And because it's one-on-one, we can keep it very concise to like 15-minute visits. So I'll put my information at the end. If you want to reach out, consider that. You have questions you want to follow up. It is free, it's unlimited, it's available as much as you need it. So I'm going to use Poll Everywhere today. So I'll let you guys set this up for a second. Go ahead and pull out your cell phones. You're going to text to that number 22333 and put in the subject Kelsey G 435. Poll Everywhere picked that for me. I did not pick that, but we could make that my new nickname at this point, Kelsey G. And then once it'll tell you that you've joined the session, and then go ahead and select one of those responses on where you feel you're at with PrEP at this point. Are you familiar, but you don't feel comfortable enough to prescribe it? You are prescribing it, but you feel like every time you have to look up how to do it. Or as a childhood reference there, you feel like you're a brown belt. You pretty much got it down pat, but you could use a few tips and refreshers. Or you feel like you're an absolute superhero with PrEP and you've got the whole thing down. So go ahead and select there, just to kind of, one, make sure everybody feels comfortable with using that system and just get an idea of where we're at. Okay. Great. All right, I'm going to go ahead and move on. Looks like we'll have the ability to cover a lot of ground here. So very basic, what is PrEP? So that stands for pre-exposure prophylaxis. This is once daily medication taken to prevent the acquisition of HIV. This is used by people who do not have HIV but are at high risk for HIV infection, either through sexual contact or injection drug use. Medications, when taken a majority of the time, reduce the ability for HIV to establish permanent infection when a patient becomes exposed up to 90%. And let me discuss that a little bit more so it's a little more clear. So this is pulled directly from the CDC. There are a lot of studies now that show the effectiveness of PrEP. You can look up and review tons of them in detail. This just did kind of an overall summary of them. So when taken the majority of the time, so when taken every day out of the week, PrEP is over 99% effective. These studies, they've confirmed this by doing blood tests. So it's not just subjective where they've asked somebody if they're taking it, they've actually confirmed that through blood test. Injection drug use has not been studied as much at this point. And when they've studied it, there's two medicines and they've used one of them. Both the medicines for PrEP come in combo of 2 pills together. So they've looked at one of those pills for injection drug use. They found in the studies, people were not taking it regularly. So when people are taking it about 4 days a week, so still somewhat majority of the time, they're kind of sitting here at 75% to 80%. So still fairly effective. 4 days a week, that's still pretty good. But we know that if people are adhering to it 100% of the time, it's extremely effective. Okay, looking at HIV in Utah, just as a little snapshot here. So in 2018, there was 122 new cases. That's kind of been where we've stayed, about 120 cases for the last 10 years, which I know when you think about overall, well, that's pretty low, right, compared to a lot of cities. But also we're stagnant, right? We're not dropping. So even with the things that we're doing, we're not seeing case numbers drop. And also screening is very, very low in Utah. At one point, there was a study in 2018 that showed that Utah was ranking 50th in the country for screening for HIV. So we're just not screening enough people. So these case numbers are probably even higher, and we just don't know that at this point. So that's one of the things with PrEP is you're going to be screening people more often, and we have the ability to see who in the population needs connection into HIV clinic and who can be protected with PrEP. And then this here is just looking also at the health disparities. So here on the left is looking at the distribution of our population for 2019, and then looking at the right at new HIV diagnoses for 2018, because that's the data we have right now. You can see that, yes, the majority of our population and new HIV diagnoses are mostly white individuals. But when you look at the breakdown compared of minorities from the population to who's being diagnosed with HIV, there's still major health disparities there. So also offering this to your patient is helping to reduce those health disparities. PrEP in the US, just a little summary here. Approximately 120,000 individuals are on PrEP right now, but the CDC estimates that 1.1 million individuals have indications for taking PrEP. So there's a lot of folks that could be using PrEP that are not either getting offered or don't have access to it. And same thing again, we also do see racial disparities. So out of MSM, or men who have sex with men, individuals that are estimated to have indications for starting PrEP, 65% of that group is Black and Latinx population. But when you look at who is actually taking PrEP, 70% of those folks are white. So also, again, for some reason, people are not getting access or not being offered PrEP that do have indications for it. So let's talk about who would benefit from PrEP and then get into the details here. So men who have sex with men, people who inject drugs, and trans individuals do have higher risk for HIV. So those individuals would benefit from PrEP. But also I think we forget that heterosexual men and women also benefit from PrEP if they're at risk for HIV. Either their partners have HIV, which we'll talk about later on specifically, or they have multiple partners, they don't know the status of their partners. Those individuals also should be offered PrEP. And the other thing that's also been added in the last year that wasn't really on there before is anyone who self-identifies a need for PrEP. So if a patient comes into you and requests to start PrEP, you do a history and you're not really seeing where the indication is or what their risk is. If they're telling you that they need to start PrEP and they don't have contraindications for starting it, they should still be offered the medicine. I think we've all had patients who over time, as we build that trust, we get more information about their health history and concerns that they have. So we shouldn't be denying somebody PrEP if they're telling us that they do have a need for it. All right, so we're gonna go through sexual health history taking. I think it's always good to review taking a good sexual health history, determining that PrEP would be beneficial, what your exam would look like, and how you're gonna be ordering labs at that first visit, medications, how you're gonna select there and send that, what follow-up visits look like, and then the least sexy part, of course, is billing codes. As much as we don't think about that as much, nothing is worse than you learn all these skills and then the visits aren't getting covered and you're having a hard time with that. So we'll briefly talk on that and then cases. So type of initial visits. The easy one is somebody just schedules to see you for PrEP, right? The other easy one, I think, for capturing someone is they come in for STI screening or concerns. That's a great opportunity to do a good sexual health history and see if somebody has indications for PrEP. The big one that I used to do for my family practice setting was also yearly exams. So in the last couple of years, PrEP has been added as a grade A recommendation by the United States Preventative Service Task Force. And if you're a family practice provider, we kind of gear our yearly visit at all these recommendations, right? And most of us are always doing mammograms, lung cancer screenings, diabetes screenings, and statin screenings, which are all actually grade B. So PrEP has a higher grade and evidence level than those other things listed there. So we really should be doing this at every yearly visit with any patient that's sexually active and making sure that they're getting offered and screened for PrEP. Contraception visits are also great opportunities. Even if it's your patient's first contraception visit and you're just kind of reviewing all the options, it's a great chance to also talk about, you're already probably talking about educating on condom use and STIs, but also talking about HIV risk and that PrEP exists, what it's for, because maybe your patient doesn't need it at that visit, but they'll know in the future and be able to make a decision if they do need to come back and discuss it. And then the one that I love is any patient that always says, hey, am I due for anything? And you haven't discussed it before, taking that opportunity. So sexual health history taking, going through this briefly. So always stating, I do this, so half my week is doing PrEP clinic. Patients come to me knowing that we're going to be talking about their sexual health. And I still always tell them that, these are questions we ask all our patients. Your answers are confidential, and this helps us determine your risks. That kind of helps make everybody feel a little bit more comfortable when you're talking about something this vulnerable. The 5 Ps kind of hit all the basics for your sexual health history. So partners, who are your patients having sex with? Men, women, or both? Practices, what types of sex are your patients having? This is going to determine how you do screening, which we'll talk about. So are you having oral, anal, or vaginal sex? Pregnancy. I always like to ask this question to my patients as, if you were to get pregnant with your partners right now, how would you feel about that? I think that has less implication than asking, what are you doing to prevent yourself from getting pregnant? Or do you want to be pregnant right now? I think that has a lot more serious connotation to it than just asking them, how would you feel if you became pregnant right now, and letting them open up that conversation and then offering contraception if they'd like to start it. Protection. So how are you protecting yourself from STIs? And then maybe beyond condoms. So I also, instead of just asking, are you using condoms, asking, how do you protect yourself from STIs? Because it may be that they are selecting their patient or their partners based on screening. So they've both been screened for STIs, so they feel it's safe to not use condoms. So giving them the opportunity to discuss that. And then past STIs. If someone's had an STI in the past, they are at higher risk for HIV. So asking about what STIs they've had in the past, when they've been treated. It's also nice to know if they've previously had syphilis, because we know that interpreting that result can be challenging. So knowing if that's going to come back positive because of past infection is nice. And then educating on condoms, vaccine options. So Hep A, Hep B, HPV, right? We have those in our clinics. If somebody hasn't had those, it's a great opportunity to offer that. IV drug use, discussing that as well. And then routine testing and making sure that you know how often your patient should be screened for STIs. If that's something you're unsure of, that's a great opportunity to reach out for public health detailing so we can review that too. And then PrEP, of course. This I'm just going to briefly touch on, but knowing if your patient needs PEP and not PrEP, PEP being post-exposure prophylaxis. If your patient has a known exposure to HIV in the last 72 hours or a very, very high risk for HIV in the last 72 hours, then you're probably going to want to start PEP, which would be one of the medicines used for PrEP and an additional antiretroviral. You would do that for 28 days, be testing for HIV, and then if they still have a continued risk, you would just move them right on to PrEP and drop that other antiretroviral. So it's pretty simple, but something to keep in your mind. If it comes up that they actually do need PEP, then feel free to reach out. There's a lot of great algorithms for just setting you up for that. So you've had that conversation, you've done your screening, you've determined that it would be great to start PrEP. What does your exam look like that day? So you're going to want to rule out or assess for signs of acute HIV infection, which I know are some of the most vague symptoms that a patient can have. But if somebody has all 4 of these, it should really be on your radar that you may be considering that they have an HIV infection. So unexplained weight loss, fever, rash, sore throat. If they have all 4 of these, and with your sexual health history, you see that there is a high likelihood that they have been exposed to HIV, this would be the one time where I would wait for all my lab results before I sent their medication for PrEP. And we'll talk about one of our cases. There's actually, it used to be that you always waited for your results before you sent the medication. We don't do that now. The research shows that if you wait to send somebody's meds for the few days it takes to get labs, 30% of the people you talk to about PrEP won't ever start the meds. So you should send them the same day, with the only exception being that if these red flags came up, then I would tell someone, let's wait for the results and then I'll send everything afterwards if it's negative. And then don't let this seem scary, but the baseline labs, I know this looks like a long list, but we're going to go over this several times. Essentially, you're doing your STI screening. So an HIV test, syphilis test, chlamydia and gonorrhea with 3-site testing, which we'll touch on next. You're going to be checking the kidneys with a BMP test. If they have the ability to get pregnant, a pregnancy test, and then a Hep B and Hep C. CDC guidelines only recommend doing the antigen testing for Hep B. We also test for antibody as well, because if somebody is not infected and does not have antibodies, then a great opportunity to give them hepatitis B vaccine. Okay, we're going to touch on that again. I know it looks like a long list to remember, but we will review that again. 3-site testing, if you're unaware of what 3-site testing is. So chlamydia and gonorrhea infections now should be tested every time by NAT, which is nucleic acid amplification test. When you order it in the chart, the NAT option comes up. We don't do PCR anymore. NAT is recommended by CDC. It's very sensitive. And it should be, your patients need to be tested at the site of sexual contact. We used to always do urine testing alone, but it's found that we actually miss a lot of chlamydia and gonorrhea infections that are in the throat or in the rectal area. If your patient is MSM, so men who have sex with men, they should always be getting 3-site testing with your PrEP visits every 3 months because of the high risk. So they need to do a throat swab, a rectal swab, and then a urine test. For women here, it says first catch urine samples might detect up to 10% fewer infections. It's still something that you can still do urine, but it is recommended that vaginal or a provider done cervical swab does catch more chlamydia gonorrhea infections. And self swabs, there's also a lot of research, self swabs of throat, rectal area, and vaginal area have just as comparable results as provider done swabs. So the option exists there for either. If you need great flyers that show how a patient can do a self swab, please contact the University of Utah, or the University of Washington's made beautiful flyers that you can put up in your labs. Just touching on that again, so this was a study that was done where they did 3-site testing on patients, and 64% of the cases were actually rectal chlamydia gonorrhea and not urine. So if urine was done alone, they would miss a lot of infections. So it really needs to be considered. Like I said, MSM is recommended by CDC to have 3-site testing. Women are not, but we do in PrEP clinic ask women what types of sex they are having. And if they're having oral and rectal sex, we do 3-site testing so we know we're not missing infections. All right, medication options. This slide looks busy, but these slides will all be posted later, so you can look at this again, and it's a great reference. And I'll just go through the big differences. So TDF, as I'll be calling it today, or Truvada, this has been out since 2012. This is the first medication approved for PrEP, probably the most that you've heard about at this point. Descovy, or TAF, was approved in October 2019. When you look at these first through sections here, so TDF and TAF are approved for MSM and trans women individuals, but heterosexuals and people who inject drugs have to do TDF at this point because that's been the only research that's been done. There's research still being done at this point to show that it also is effective with TAF, but we don't have those studies. So FDA-wise, you're only covered with TDF for your heterosexual and individuals who inject drugs. So something to keep in mind there as a difference. TDF is also becoming generic in January. So in terms of like an insurance coverage, you'll probably be leaning heavily on TDF unless there's an indication to use TAF. And those would be, looking down here, this GFR, so kidney, there's been a lot of hype that TDF can be bad for your kidneys. The understanding there is that TDF, essentially it processes through your kidneys and it can cause that GFR to drop, as it shows here, about by 2 points. if you have a healthy individual with no kidney problems, that depression in their GFR is not going to be harmful or put them into a category that's concerning. And they found when they follow individuals taking TDF for years, when they stop taking it, even after 7 years, this returns to normal. So there is no permanent damage that's occurring. But if someone with very concerning kidney function, you may be considering TAF instead, since you can use that to a lower creatinine clearance, which will be on the next slide. Bone loss, there has been shown to be a small amount of bone loss that they've seen. That does not return when they stop, but they have not seen where it causes any increased risk in fractures. So even though there's a little bit of loss, that has not been shown to be harmful significantly. And then the one side effect here, which was also on the next slide when we look at our medications, is TAF can, oh, sorry, maybe not quite on this one. TAF can have a little increase in body weight by 1 to 2 kilograms, which for some patients is a huge deal, right? So they're not going to want to take it. So something to keep in the back of your mind. As we talked about, send medication same day unless they're having acute symptoms of HIV. When you're looking at kidney function, the TDF or Truvada can go to a creatinine clearance of 60, where TAF can go to 30. So that's one way that insurance would definitely cover your TAF or Descovy for you, is if somebody needs to take it because of kidney issues. Hepatitis B and C testing. We're doing this because we want patients to get treated if they have hepatitis B and C. It does not mean that they can't have PrEP at that point. If somebody came back positive, you would want to then do some liver function testing, make sure nothing acute is happening in terms of concerns for fibrosis or cirrhosis, and get them into GI to start treatment. But if they're still at high risk for HIV, you would continue to do PrEP. If they did have fibrosis and cirrhosis, you need to have a discussion with them that they cannot stop their PrEP without a taper, or they can have a flare of their hepatitis. But if they have no fibrosis or cirrhosis, so their liver function looks great, they just have the infection that needs to be treated, they're going to be safe to do their PrEP. Even if they stopped it, they'd still be safe. So I don't want that to be a reason that somebody doesn't give it to someone. Obviously, if that came up and you felt very nervous still, then reach out to one of us at Infectious Disease Clinic and we can help kind of talk you through it and make sure that you still feel comfortable. But these folks should still be offered PrEP. All right, sample billing codes. So the big thing is that there is no main billing code. You don't have to use a specific one to be covered. All of these are options. I know that the doctor I work with, she likes this Z11.3 because she feels that that word screening, insurance tends to cover screening exams a little bit better. I've always used this Z20.6, even in my family practice in Washington, and I never had a problem with getting visits covered. You can use counseling codes if you want to. Honestly, after your first visit, even though this seems like a lot right now, these visits used to take me 5 minutes for follow-up PrEP visits. They're very, very streamlined once you've done all that initial work. So I would add them into other visits, a 3-month diabetes, 3-month hypertension, mental health follow-up, contraception visits, and I would just tag that on as a follow-up, discuss their PrEP briefly, and then move on to the other reason that they were there. But if you're someone that's spending 15 minutes, doing counseling at every visit, you can use that code as well. Okay, so here's the other, so just a few other things with the medication. You want to be able to tell people, how long do you need to take this before it's going to actually protect you from HIV? So patients who are having anal receptive sex, need to take it a continuous 7 days before it's protecting them. That's the same for TDF and for TAF. For vaginal receptive sex, you need to take it for 21 days before it's been found that the medication is actually present in those vaginal tissues. So you need to make sure that you're informing people that they need to take it for full 21 days prior to, considering not using condoms. Side effects tend to be similar in terms of upset stomach. For both of these meds, it goes away usually within a week, if not 14 days. I've offered patients Zofran if they need it. I've only had one person ever take me up on that. They said it's not very bothersome. As we talked about TDF and kidney concerns, I always just caution people about NSAIDs with their TDF. And then we talked about the weight gain with TAF. It is contraindicated with St. John's wort. I feel like that St. John's wort just interacts with a lot of stuff. So, and supplements tend to be, I feel like, a little bit more common here. I've noticed with a population in Utah than some of the populations in other states. So I would always ask people if they're taking supplements and which ones, so you know that you can counsel them about that. There's not a lot of other medication interactions. Um, there are some antipsychotic. If you have patients on a lot of antipsychotics, just double check, but these are the big things that you would be looking at. PrEP costs, just a couple more slides before we do cases. I know it feels a little overwhelming. PrEP costs, these medications cost a lot, right? Antiretrovirals are somewhere on the cheap side of $1,800 and up to $2,000-$3,000 a month. So like I said, so patients who have insurance, TDF will be generic in January. Even now, because this is a grade A recommendation, is getting covered by insurance. When I work with providers in the public health detailing, they do not have problems with getting their patients getting it covered. If somebody does have comorbid conditions that they need to be on TAF, then it's also getting covered, I found, without a problem. These are the two main pharmaceutical companies that are making these medicines. They have financial assistance programs. So the PrEP clinic I work at, it is free for patients who do not have insurance. So they can do prescription cards that cover 100% of the medicine, but there are also copay cards that will cover usually up to about $7,000 a year. So even if their copays are absolutely ridiculous, they can get some assistance there. And then this website at the bottom, Please Prep Me, it has a lot of fabulous resources for both providers and patients. So if you still feel like you're having some problems, one, reach out to us. We can always help figure things out. But two, this is also a great resource to look at. Follow-up visits. So your patient will be coming every 3 months to see you to get a refill and then also assess, how are they feeling? How many missed doses do they have? That's always a great question because you want to know, are they having gaps for several days at a time? I just had a patient who the pharmacy couldn't get the medicine in time and they went about 5 days without the medicine. And it's good at that point to know, were you having unprotected sex during that time? So that way, if somebody does end up coming back HIV positive at some point in the future, you can kind of have an idea of, where did the gap occur that we had that missed doses or, that risk that was created that they got exposed. And then also of course, the opportunity of how can you remember to take it if they're really struggling with remembering. Symptoms of STIs, brief exam to make sure they're doing okay. And then these are your labs that you'll be looking at based on the visits. So always, no matter what visit they're on, you're going to be doing an HIV and STI screening. I put here the chlamydia, gonorrhea ×3 for the 3-site testing. If you have patients that are only having, vaginal sex or vaginal oral sex, it may be that it's just 2-site testing. But, if they're MSM, I would strongly encourage you're always doing 3-site testing. If they have the ability to get pregnant, always checking a pregnancy test. If they came back positive, you still should be doing PrEP. The risk of HIV outweighs the risk of side effects from these medicines. So they are considered safe to continue in pregnancy. But it's something that your patient's sexually active, you want to know if they're pregnant at that point so you can get them connected to care. And then kidney tests are done every 6 months. So at your initial visit, 6 months later, you're doing another kidney test. At that annual 12-month visit, you're doing a kidney test. And then once a year, you're doing a Hep C test. So there's not too many changes happening there. As long as you're hitting these major ones and then, just reviewing the previous visits to see when's the last time I did a kidney check? Oh, it's been 6 months, time to put that in there. When's the last time we did a Hep C? It's been a year, I'll plug that one in there. You're going to be hitting all the marks at that point. Any major questions that I can't see the chat box? Is there anything that's come up?
Nothing so far, Kelsey.
Okay.
Yeah.
Then I will jump into cases. Hopefully those will answer any questions you guys have as we go along. We'll have that poll everywhere as we go. Okay, so 27-year-old cis male comes to clinic requesting PrEP. He reports he has sex with men only, anal receptive and insertive sex, so also called verse or top-bottom sex. He has one consistent partner and then about 2 new partners a month. he uses condoms occasionally, had rectal chlamydia last year. Is he a candidate for PrEP? Based on his history, do you feel like he would be a patient that would be a good candidate to place on this medicine? Great. Easy peasy, right? We'll start off with simple. So this is an initial visit. What labs does he need done today? And you can change it too if you want. I'll give you guys a second. I know I just went through all those labs and now I'm expecting you to remember them, but let's see. Nice. Okay, great. Yeah, so at his initial visit, he's going to need all that STI testing and HIV, 3-site testing right for MSM, kidney check, both hepatitis and Hep B. That first letter A would be at a follow-up at 3 months, but we really would rather have that 3-site testing, so B would be a good 3-month follow-up. And then that last option was your 6-month follow-up there. Okay, let's move on. So which medication would you start? I know this looks like a little bit of a trick question, but go ahead and pick the one that you think is best. And give you a couple seconds there. Okay. All right. You can keep answering if you want. So 50V, that's a completely acceptable answer, right? So this patient is MSM. As far as we know, he's healthy, doesn't have kidney problems at this point. So he could do TDF or TAF. Either are acceptable for him. He does have the option for both. Maybe insurance would end up determining, if he had to kind of qualify for one or the other. But in terms of like our clinic, our free PrEP clinic, we can get assistance for either one. So they're both acceptable. These options on demand or PrEP 211, I'll just mention them briefly in case the patient brings them up. So on demand, or also called PrEP 211, is when a patient is taking the medicine just around the times that they're having sex. So 211 stands for taking 2 pills within 2 to 24 hours prior to sex, 1 pill 24 hours after sex, and 1 additional pill 48 hours after sex. So there's been research that has found that this is very effective for preventing HIV. It has only been studied in TDF, so you would not have TAF as an option for that. And the other big caveat, it's only approved at this point in Europe and I think Canada. So the FDA has not approved TDF to be used this way, even though the research exists. We do discuss it with patients in our clinic, but I would say it's an off-label use. We feel comfortable with that, and all we do all day long is PrEP. If you're a new provider to PrEP, that may be something that you don't feel comfortable doing, which is completely acceptable. But patients may ask you for it, so knowing what it is. And if somebody is really feeling strongly about doing it, there's great infographics for patients to have so they know how to do it correctly. So you can always reach out to us there. But if somebody's having sex 3 times or more a month, you're going to at that point be taking the medicine most of the time. You might as well take it every day. So that's the big thing we tell patients too. This is really if you're having sex 1 to 2 times a month that this makes sense. Okay, moving on. So 34-year-old cis female comes to clinic for STI testing. She reports that she exchanges sex for marijuana among a group of male and female partners that she has. She reports she has anal and vaginal intercourse with these partners. She only has STI testing when she has symptoms. And her last test was about 9 months ago where she was found to have gonorrhea. She uses condoms about 50% of the time. Which one of the 5 Ps has not been discussed at this point in that visit? I know I read through that fast, so that might have been a little unfair. Okay, great. Yeah, so we had no talk in there about pregnancy, so that might be something to ask her. What type of testing would you do for chlamydia and gonorrhea for her? Which option would you choose to perform? All of these are NAT as recommended, but are you going to be doing multiple site testing, urine swabs? Which one would you choose? Obviously, more than one could be correct. Looks like we're all feeling very strongly about it. Oh, there we go. Okay, so she reported to us that she's having vaginal and anal intercourse, right? So at the very least, I would probably be doing a vaginal and a rectal swab. I would at that point ask, are you ever having oral sex, or have you ever? Because then 3 sites of testing at that point would probably just be great to do. At the very least, I would probably be doing a rectal swab and a vaginal swab, but urine is also acceptable. That's still an acceptable test to do a urine NAT test. You can offer, if she wants to do a self-vaginal swab. If you're already doing an exam that day, then a provider swab would make sense. But I probably wouldn't just do urine alone. But also the CDC doesn't recommend that you do 3-site testing on women every time. So there is some leeway here. I would just say more information is better, right? So you're not missing an infection. All right, so you start PrEP for her and send her initial labs, and then her gonorrhea returns positive on the vaginal swab. So bonus question, how are you going to treat her gonorrhea? Let's just see if you guys have this off the top of your head. And if not, that's okay. You can always Google the CDC STD guidelines, which pop up easily and have beautiful graphics for flowcharts on how to treat those patients. Also, something you can always do public health detailing. We have handouts as well and can talk about new updated guidelines. Yes, looks like so far we are all feeling strongly about B, which is correct. That is what we would be doing. All right. Does she need to stop taking her PrEP while she's on antibiotics? I actually get this question a lot from patients when I send them treatment. They ask me, should I stop taking the medicine until I'm done? Okay, so the answer would be no. There are, besides the contraindications like we talked about, St. John's wort, or like I said, some of the antipsychotics like lithium, you are fine to continue your PrEP. And at that, if somebody had those contraindicated medications, there need to be a discussion on, the importance of PrEP and maybe stopping or adjusting other things. But in terms of antibiotics, they are fine to take them together. So continue your PrEP. I always tell patients, I don't want you to have a gap in your PrEP medicine. I want to make sure that you are covered. It won't interact with your PrEP. It won't interact with the strength of the antibiotics. Keep going with it. And then she asks you, how many days do I need to take my PrEP before I can stop using condoms? So she's having both vaginal and anal sex. So how long does she need to take it before she's going to have that coverage and protection? Great. I love that we have variety in the answers. It allows us to talk about it a little bit more. So the 7 days continuous use at that point would protect you from anal contact with HIV. So it takes 7 days for PrEP to show up in rectal tissue, but it takes 21 days for it to be present in vaginal tissue. So yes, she would be protected if she was having just anal sex at day 7, but vaginal intercourse, it needs to be at 21 days. And then I love that nobody picked just the plain 7 or 21, always taking the opportunity, right, to let them know, you'll be protected from HIV, but PrEP will not protect you from STIs. So make sure that, you know your partners, you're aware, try and do your best to protect yourself from STIs. Okay, you have a 47-year-old trans female patient who's on TDF for PrEP. She follows up for her 6-month visit. She reports she has a hard time remembering to take her pill and is taking it about 4 days a week. Just a little review so we know approximately what coverage or effectiveness is her TDF right now with taking it 4 days a week. And I won't spend too much time on this. Right, so she's about 75%, maybe 80%. And I, at that point, I let patients know, you know, you have some good coverage right now, but I really, we've got to find a way to help you remember, right? So we can get you over that 90% effectiveness. And then discussing too, are you missing the same days in a row? Are you having unprotected sex when you're forgetting it? Getting a good idea of where they're at right there. She's at her 6-month visit. What labs does she need today at her 6-month visit? Excellent. Yes, she needs her STI or HIV and a kidney check. Perfect. Okay, so this is a word waterfall. So try and type in 1 or 2 words of ideas on how she can remember to take her pills, and they will pop up on the screen. Yes, right? An alarm, especially like on your phone. Yep, a reminder of some kind. Good. A pill box, I see that in there. Toothbrush, yes, right? Put them next to your toothbrush. If you're good at your dental hygiene, that should be an easy way. Excellent, excellent. Yeah, so I said there's the keychains too, right? If you have a patient that kind of moves around a bit, maybe stays with other people, having at least 3 pills on them on their keys is good. Also, these reminder caps. So there's caps that have alarms or tell you how long since the last time you opened your pill bottle. So that can also be an option, something they can get. All right, we have just, I think, 2 more cases that I'll move through and then I will be done. So we've got a little bit of time at the end. So 39-year-old cis female patient presents for a women's health exam. Reviewing her social history, she reveals that she does inject drugs for the last 4 years. She's been decreasing her use on her own, but she's not ready to quit or start rehab. But she is interested in starting PrEP. And her labs, so you decide to start PrEP and her labs return positive for hepatitis C. Can she start the PrEP while she's infected with hepatitis C? Yes, perfect. Okay, move on. Which medication would you start for her? This is a cis female patient who has history of injection drug use. Ooh, 50-50. So we would want to lean towards TDF since that has been FDA approved for heterosexual women and those who inject drugs. We have used TAF for heterosexual women in our clinic. There is research being done that shows that it is still effective, even though it's not FDA approved at this point. But probably the only reason I would lean that way is if like her kidney function was not at optimal place. Okay. All right. So you have a 29-year-old male that comes to clinic to discuss PrEP. He reports he has a new partner who is living with HIV, but that partner is undetectable, so undetectable viral load. And he would like to start PrEP because he's very nervous about becoming infected with HIV himself. Would you prescribe this person PrEP? Okay, so the big thing here, so U equals U. So undetectable equals untransmittable. So this is just one website. There now is a lot of research that shows that once you have an undetectable viral load, you cannot transmit HIV at that point. So your partner does not need to take PrEP necessarily to avoid becoming infected with HIV. We have a lot of patients in our PrEP clinic that have partners with undetectable HIV, but they just feel very nervous about it, right? It's something that they feel uncomfortable with. They want to be on the medicine that they know they're safe. And we don't deny PrEP to those individuals. We do start them on PrEP as long as they don't have any contraindications for the medicine. But it is a conversation that we do have, because every once in a while you will have a patient that says, now that I know this information, I'd rather not take a pill every day if I don't need to. So it's something to discuss and make them aware. But like I said in that first slide, if somebody identifies they need PrEP and they feel comfortable that way, then that's fine. We'll continue on with that. Okay, last case. A 16-year-old female comes to follow up for her depot injection, and she has concerns for chlamydia. She states that she has an average of 3 male partners a month, and she doesn't know if they get tested for STIs, and she rarely uses condoms. Can you prescribe this 16-year-old PrEP? Is she a candidate for taking PrEP? Absolutely, right? So TDF has been approved for anyone 13 years and older who has an indication for PrEP. The doses will change between 35 to 17 kilograms. There's a few different ranges where you would adjust it. The minimum weight being 17 kilograms. And then in the state of Utah, it is important to know that 14 years and older can be seen without a parent or guardian for PrEP. So they can come in to start that. So that's good to know if somebody comes in and tells you they need to start that. Okay, so in summary, screening all your sexually active patients and people who are injecting drugs for the need for PrEP, assessing for acute HIV that day and doing labs, sending them medication that day, either the TDF or TAF for 30 pills and 2 refills. I've not found an insurance yet that covers doing 90 pills. I know that's convenient, but most of them want you to send it as a 30 pill with 2 refills. And then following it every 3 months to reassess, do labs, send them a new refill. That's very, very important. We have actually had patients, unfortunately, that come to our HIV clinic to be seen with an HIV infection who were getting PrEP, but weren't seeing their provider very often. We're going in every 6 months or a year, and we're all humans and we forget to take our pills. So having those visits to check in on your patients, see where they're at, and remind them is very helpful. And that's another way to prevent and reduce risk for HIV is just having that check-in to remind them to take their meds. My contact information, my email, please reach out if you have questions. You want to do public health detailing, you just need an answer to something. Phone number for my office, email is better. Laura Martell, who's also on with us today, she's the program manager for our AIDS Education Training Center. So if you had other questions about HIV training, CMEs, stigma training for providers or staff, all kinds of programs and availability through our AIDS Education Training Center. So please reach out to us if you need anything. And then references there. Like I said, these will be shared. Caitlin will share these, and I'll turn the time back over to her.
Great, thank you so much, Kelsey. And we did have a couple of questions come in. One was in reference to one of your first few slides about the recommendation for all trans women to be screened or to be on PrEP. And the question is, should you not first understand their sexual history?
I'm not quite sure. The question was, should you not first understand their sexual history? Maybe we're referring to, so patients who transgender individual patients, so trans women specifically, and MSM, so men who have sex with men, have been shown to have higher risk for HIV. There's a lot of reasons for that higher risk, not just that those patients tend to have more anal sex, which is a higher type of sex or higher risk for that type of sex. So making sure you're always screening those patients. But yes, you could do a sexual history. And this is a good point if this is what you're getting at. I've had patients come to me that are MSM and they've said, my provider told me that I needed to start PrEP because I'm MSM, but I only have one partner and we both get screened and we have no other partners. So that person does not necessarily need to start PrEP, right? They don't have risk factors for it. So absolutely, you're screening all those patients, but it doesn't mean that they're going to have indications or need to start PrEP at that point, but you don't want to miss the opportunity of offering it to them.
Great, thank you.
Mm-hmm.
And we're continuing to take questions in the chat, or if you want to unmute yourself, so feel free. I also had a question about what common concerns come up from clients when you present info on PrEP. Are there issues about stigma associated with taking PrEP, or is it more about side effects? What tends to come out of your come up with patients?
I would say a lot of our patients, so a lot of patients in our PrEP clinic are MSM. So a lot of them have done a lot of research before they come to us. So there's a lot of information out there that TDF or the Truvada can be harmful to kidneys. So people often want to discuss that, make sure that what that risk is and understand what the potential side effects are. Um, Also, I would say, like I said, a lot of patients ask if it's going to interact with other things. Um, those are probably the biggest things that I get. Honestly, the stigma is actually usually reversed for us. Most of our patients, they come because their friends are on PrEP. And so they want to start it as well because they feel like most of their friends or their partners are already taking it. And they need to be doing that extra step as well to protect themselves. So we kind of have the reverse in our clinic.
Great. And then I just have one quick question about going back to the on-demand, the 211
Yes,
the PrEP. So, and I think you mentioned it requires taking it before the sexual encounter. Is that right?
right, right.
And I'm just thinking, some folks might not know when there's the next sexual encounter is. Does that come up in counseling too about this would have to be for a particular client and with a particular sexual kind of routine or practice?
Right. So we definitely are not like advertising that and offering it as a way of, if you'd like to do it this way, you can. It's more patients say, hey, I've heard of 211. Is that something I can do? And so we do discuss one, if you have sex more than 3 days a month, you're going to be taking at that point like 13, 14 pills, doing even 211. You might as well just take it every day. That way, you know that you're protected. And if you want to do it as 211, then you do have to be on top of how you're taking it so you know you're protected, which is why I send people infographics that list out the hours in which they have to do it. The only time I've really had patients do that is patients who know, whenever I travel for work 3 times a month, and there's one partner I have in this city that I see. So I only want to take it when I'm going to see that partner. So then they can plan a little bit better. And the initial window is like 2 to 24 hours. So maybe you're going to have a little bit of planning time there. But yeah, you definitely have to be more on top of it to make sure that you're scheduling that correctly.
Great, thank you. And we did have another
Mhm.
question come in from a participant. We had a patient who wants to be on PrEP, but is very hesitant due to fear of lab blood draws. Any recommendations for how we might be able to minimize lab draws?
So there are some creative ways now. So I have to say that COVID has brought out some interesting ways all over the country for PrEP. So now there are at-home testing kits that do HIV oral swabs and finger stick for the syphilis and the BMP. And then you can do, rectal swabs, vaginal swabs at that point. So if they could get over, like if they're okay with a finger stick, then they could still do those tests at that point. Just ordering one of those kits might be a little bit expensive. There's some companies that have them all set up. I think there's like 3 or 4 options for at-home testing kits. So that is an option to look into. And feel free to email me. I can send you the names of those at-home testing kits if they wanted to look at that. The oral swabs for HIV are not the best. Definitely, if anything ever came back questionable on a result, then you would definitely want to talk with the patient where the need for a blood test would be better. But that option exists now, which is kind of cool.
Great. And we're just getting a lot of comments about thank you for the presentation, and this was very helpful. So thanks so much.
Oh, wonderful.
And I have just a few closing slides so that folks can claim CME credit. We will be emailing the code and instructions for claiming that credit after the webinar. And just a note that it has to be claimed today. So if you try it tomorrow, that code won't work. If you're having trouble, run into any difficulties, feel free to drop me a line, caitlin.quaid@hsc.utah.edu. And then lastly, we just ask that you complete our post-webinar survey. Just like the pre-survey, there are a few ways to get there. You can type the URL into your browser right there. Click on the line in the link in the chat box or hover your smartphone camera over the QR code. And the survey will ask if the webinar has taken place yet, and just make sure to answer yes so that the appropriate questions appear for you. It has been an absolute pleasure hosting you today. We hope you continue to join us for new topics in our webinar series. And thank you all so much. Take good care of yourselves. And with that, I will leave you to the survey.